Hi, everyone. Good morning. I'm Kristen Holler. It's my pleasure to introduce our first session this morning. We're happy to be joined by doctors Jesse Lester, Sang Lee, and Michael Liaker. Dr. Lester is going to start us off. He's a critical care anesthesiologist at the Ohio State University Wexner Medical Center in Columbus, Ohio. His clinical focus is in the CVICU, specializing in the care of a full spectrum of surgical cardiopulmonary disease processes, including mechanical circulatory support devices such as ECMO and VADS. He's also the physician lead for Ohio State's Cardiac Surgical Unit Advanced Life Support Program. He'll be speaking to us today on the Cardiac Surgical Unit Advanced Life Support. Please welcome Dr. Lester.
All right. Hello, everyone. Thank you for having me. Again, I'm Jesse Lester. I'm one of the intensivist anesthesiologists at Ohio State in Columbus, Ohio. So I'm going to talk to you guys a little bit about when we started at Ohio State, it was a relatively novel thing. I think it's becoming a little more widespread as we go along here, but the Cardiac Surgical Unit Advanced Life Support Protocol, which was developed, so I have no financial disclosures. So objectives for my presentation, we're going to talk a little bit about what CSU ALS is and why it's necessary. We're going to contrast it a little bit to the standard ACLS protocol, which many of you I'm sure know very well, and I'm sure some of you have at least heard of CSU ALS. But we're going to talk about the protocol, the specific roles it involves, and then describe the process of the emergent resternotomy, which is one of the basic tenets of CSU ALS, and then we're going to discuss a few special considerations. So why is this necessary? So this was developed by a surgeon named Joel Dunning in the United Kingdom in the early 2000s, and basically he felt that his cardiac surgical patients were sufficiently different from other patient populations that a separate dedicated protocol was justified. And some of his reasoning was basically that in this patient population, well, first of all, starting back with ACLS, I mean, there's a lot of things in ACLS that make sense in an outpatient not an outpatient, but outside the hospital scenario, right? And cardiac surgery patients are often very well monitored at the time of the arrest, and they also have a high incidence of reversible causes. And in addition to that, this patient specifically with the presence of a recent sternotomy incision and with the bone saw on the sternum are susceptible to injuries from standard external cardiac massage. So with that in mind, this protocol was developed, and then it's been subsequently endorsed by the STS in 2017, which made it a little more official, which is right before we at Ohio State decided to try to train our staff and implement the protocol. Okay, so again, why this protocol exists. So standard ACLS is ineffective in the most common causes of cardiac arrest after cardiac surgery, which are listed here. So tamponade, profound hypovolemia, bleeding, and then tension pneumothorax. So with those things, standard external cardiac massage is generally going to be not that effective at appropriately resuscitating the patient. And it's generally thought, based on this protocol, that performing a rapid resternotomy as quickly as possible is going to be your best bet for a couple of reasons. You get better perfusion, which I'll kind of lay out a little bit of data to support. And then you can also better treat and resolve the primary cause of the arrest once you're in the chest to physically get in there and obviously take care of things. So, okay, so the next few slides are borrowed with permission from the CSU ALS of North America group, but cardiac arrest after cardiac surgery is different. Talking about outside hospital cardiac arrests, there was about 326,000 arrests per year at the time of the writing of these slides, and the survival to discharge, as you can see, especially with good neurologic recovery, was pretty dismal. Then compare that to roughly a little over 200,000 in-hospital cardiac arrests per year, and the survival to discharge was still poor, but much better than it was outside hospital. Makes sense, right? If you're in a hospital and you have trained providers around you, you're bound to have a little bit better survival. But then if you look at post-cardiac surgery arrests per year, obviously the number's less, but the numbers look a lot better. And it's thought to be because this high incidence of the readily reversible causes. So usually if these patients arrest, it's due to a concrete cause that we can figure out what it is by getting back in the chest. And there's also a high incidence of shockable rhythms, which is also correlates with the people who have the best chance of survival, which I'll talk about our approach to that here in a minute. Okay, so the evidence for early resternotomy, just two studies from around the time of the writing of the protocol in the early 2000s in the United Kingdom. Basically, they One of the hospitals, Papworth Hospital, recommended reopening within 10 minutes based on a case series of 80 resternotomies over 6 years. And the same at another hospital, 72 resternotomies over 4 years, and subsequently they recommended rapid resternotomy that is chose a different time frame, 5 minutes instead of 10. So the reason I included this slide is just to illustrate, I think the standard ACLS algorithm has gotten a little bit tedious, in my opinion at least. Looking at this, you can kind of see how there's a lot of things going on. I know most of the people in this room at least are very familiar with this protocol, but it's got a lot of moving parts. And if you compare that to our CSU ALS algorithm, it's a lot simpler. So I know the slide's not that big, but on the left side there, you can see there's essentially 3 arms of the protocol. So if the patient has an arrest, if they have a shockable rhythm, then you deliver 3 stacked shocks, which I'm going to tell you about the support for. And you don't do standard CPR for 2 minutes as you do for ACLS. If that doesn't work, then you start basic life support while you prepare to open the chest. The second arm there, the yellow one, is if they have bradycardia or asystole, which if any of you work in a CVICU ever, you know that's a pretty common incidence as well. Those patients, especially if you have epicardial wires, you can attempt to pace them. And the important thing about this protocol is in those 2 scenarios, the shockable rhythm as well as a paceable scenario, you actually have the leeway to not do external cardiac massage for up to 60 seconds, which really freaks everybody out the first time you tell them that. But again, if you factor in the fact that these patients are at very high risk of suffering damage from external cardiac massage, if you can reverse the cause before you do that damage to them, it makes a little bit more sense. And then the third there is if they have a pulseless electrical activity arrest, then you do default straight to basic life support, and then you prepare to open the chest because the likelihood of bleeding issues or tamponade becomes much higher. And then the image on the right is basically an illustration of the protocol, which I'm going to go into more in depth in a few slides, so I'm going to skip over it for now. Okay, so some common causes of cardiac arrest in cardiac surgical patients listed here and their treatments. So VFib, VTAC, as I'm going to illustrate here in a minute as well, defibrillation with 3 stack shock is recommended in this protocol. Bradycardia or asystole, you can try pacing. And it's important to remember these are the 2 scenarios where you can justify not doing external cardiac massage for 60 seconds. I know speaking from our experience at Ohio State, we had a lot of issues where it became where staff was actually, we trained them in this protocol, and it's obviously pretty drastically different from ACLS. And then we had incidences where people were waiting 5, 6, 7 minutes in an arrest scenario to start CPR because they were afraid to do it. So it's important to realize this is not a protocol that says don't do CPR. It just says in these 2 specific scenarios, you can delay it for up to 60 seconds, but no longer than 60 seconds. And then, of course, PEA, tamponade, major bleeding, most readily treatable by the emergent resternotomy. Okay, kind of just went over this slide, but it is acceptable to delay for up to 60 seconds total, in a shockable scenario or a paceable scenario. And in either case, no matter what is going on, if it's been longer than 60 seconds, the correct answer is you start external cardiac massage while you prepare to open the patient's chest. Okay, so why do we do 3 stack shocks? So most of you who regularly practice ACLS in their resuscitation scenarios know that it requires you to do 2 minutes of CPR, and then you do a rhythm check, and then if it's appropriate, you deliver 1 shock, and then you immediately defer back to standard ACLS, external cardiac massage, for 2 more minutes. So that's 4 minutes of CPR that the patient's going to get, regardless of whether the shock is appropriate or if it worked. But in our scenario, if you look at the success rates of shocks for shockable rhythms, you can see it's fairly high at the first one, but then it goes down significantly to the second and the third. So basically, our protocol was designed to do 3 stack shocks right in a row. You do a shock, you do a rhythm check, you do a shock, you do a rhythm check, you do a shock, you do a rhythm check. And if you can do that in less than 60 seconds, if they still have no pulse, then you default to external cardiac massage and you start the preparation for the open chest. Okay. And then evidence for early defibrillation here. So just another study that was done in the New England Journal. Also, again, a lot of these studies now are kind of old, but a lot of these were used as the main tenets to develop the protocol about 15 or I guess 18 years ago now. But you can see survival to discharge is the important thing that we're looking at here. And if you do defibrillation with less than 2 minutes, the survival to discharge was significantly better than if you waited the 2 minutes, which kind of contradicts a little bit of what is in ACLS. Okay. And then just another bit of data in support of evidence for stacked shocks. So there was a multi-center retrospective study for in-hospital cardiac arrest from VFib or pulseless VTAC. And then they did the study and they got ROSC more frequently, which was significant, and then also had better survival to discharge with 3 stack shocks. Okay, so moving on from the stack shock situation, we're going to talk a little bit about pacing. So again, in a CVICU, most of our patients come out of the OR with epicardial pacing wires. And if you have a severe bradycardic or asystolic event leading to an arrest, this is scenario number 2 where you can wait up to 60 seconds to start cardiac massage. And in that situation, obviously making sure your leads are connected and making sure they're working appropriately. The quickest way to get I always tell my residents, the quickest way to figure out if your pacing wires are going to work is once they're plugged in and physically going into the patient, hit the emergency button. The emergency button on that pacing box will default to the highest output possible, and it also makes it asynchronous, which means any issues with sensing it's going to take out of the equation as well. So, and again, keep in mind your 60-second time frame. And if whatever you're doing, no matter the scenario, is going to take longer than 60 seconds, the answer is you start cardiac massage right away. Okay. All right. Again, external cardiac massage associated with potentially fatal complications in our cardiac surgery patients. So again, just think about the fact that their sternotomy has been recently sawed in half, and there's bone spurs and things like that. And yes, it's been sewn together, but pressing that down into a recently operated on heart obviously doesn't seem like the best idea in the world. Also, if you keep in mind patients who have cabbage grafts, the most common graft is usually a lamina LAD, which traverses just anteriorly across the heart. So obviously not the best scenario for you to be pounding on their chest and compressing their chest by the recommended 2 inches or whatever it is. And again, more importantly than that even, if the situation is readily reversible, it doesn't make sense to expose them to that risk if you can treat them and get that better in a reasonable amount of time. Okay, so internal versus external cardiac massage. So another argument for rapid reopening of the patient's chest is not just that, so the first argument is obviously that you can more readily treat common causes of the arrest, meaning bleeding, tamponade, things like that. The second argument is that we have pretty good evidence that you have much better perfusion pressure and much better likelihood of ROSC if you do internal cardiac massage versus external. So higher coronary perfusion pressure obviously correlates with an increased likelihood of ROSC. You get superior organ blood flow, which it would make sense that your survival rates would be better if you compare that to external cardiac massage. And then they do, at least in the writing of the recommendation from the STS, they did comment on abdominal compressions, and essentially they said, they didn't have enough data to support or refute that. So we generally don't recommend that, at least in our ICU. Okay, so again, old data, but some of the arguments for internal versus external cardiac massage. So there was a case study of 100 patients, which essentially they determined that comparing pressure in the aorta to the right atrium, they needed a delta pressure of about 15 that was necessary for, but did not necessarily guarantee ROSC. So if you accept that, then they talk about a case series of 10 patients who were done, I believe these were trauma patients in an ICU. I can't remember where the study was done. But they took 10 patients who failed a trial of external cardiac massage, meaning they pronounced the patient dead. And then they did a thoracotomy and did internal cardiac massage. And they actually were able to achieve ROSC in 3 of those patients who were already declared dead. So, and then you can see the data there. If you accept even somewhere near 15 as necessary for ROSC, you're seeing open cardiac massage with rates or pressures of around 30 and closed with pressures of around 6. So it would make sense that internal cardiac massage is superior. Okay, so we talked a little bit about coronary perfusion, so now we're going to talk about cerebral perfusion, because obviously if you're not perfusing the brain, kind of what's the point of the resuscitation in the first place, right? In this study, they studied closed cardiac massage versus open cardiac massage, and they compared cerebral perfusion pressure, and again, they were targeting greater than 15, and you can see the numbers in the graph there. I mean, they were drastically better with open cardiac massage versus closed cardiac massage. So just another data point in support of getting in the chest as quickly as possible. Okay, so some of the other things with the protocol. So epinephrine, obviously a common drug used in standard ACLS algorithms, and we generally use 1 milligram at a time there. So that's generally discouraged in this patient population, with the thought being, number one, and the most important thing is that there's no proven survival benefit with epinephrine boluses in arrest situations. And then there's thought to be an increased risk of bleeding with a severe hypertension response, assuming you're able to achieve ROSC. So generally in the protocol, and this is the way we've sort of adopted it into our practice, You don't give epinephrine unless you're advised by the senior clinician present at the code. And if you're going to do so, then almost universally, we tend to use much lower doses than 1 milligram. I think a typical starting dose for us is around 50 to 100 mics. So that's epinephrine. And then atropine, which is also part of the ACLS algorithm. Generally not recommended, with the thought being that there's also no proven benefit to atropine. And if you waste time trying to get atropine ready and given, it's only going to delay the ultimate treatment, which is going to be something more definitive than the atropine. Amiodarone, in the presence of VFEB or VTAC, if you do the 3-stack shocks, you can give amiodarone at the discretion of the senior clinician, although no medication should delay resternotomy if in fact it's indicated. Okay, so this is the part where we'll talk about the actual protocol a little more in depth. So this is just the same diagram that was shown in that slide a little smaller earlier, but as you guys can see, there's 6 main roles, and it's sort of like described as a pit crew model. So 1 through 6. Number 1 being the bedside provider. Number 2 being the airway provider. Number 3 being the person responsible for defibrillation as well as pacing, so the sort of the electricity person. Number 4 is the team leader, or the person quote unquote running the code. Number 5 is the person for the medications, and number 6 is the ICU coordinator. So I'm going to go into each of these roles a little more in depth to help it make a little bit more sense. So okay, role number 1, the external cardiac massage. A lot of times this ends up sort of by default being the provider in the room, usually a bedside nurse. But this person is responsible for obviously initiating the code and calling for help. If it's indicated, they're supposed to start external cardiac massage. And then if it's a defibrillation scenario or a pacing scenario, they're the ones who sort of start the preparations for that process while help arrives. Again, similar goal rate of compressions as standard ACLS, and then monitoring for effectiveness of their compressions. And if you can't achieve a systolic over 60, the thought is that you should immediately default to a resternotomy, because the likelihood of it being due to tamponade is much higher, or hypovolemia, both of which are more readily treatable once you're inside the chest. Okay, role 2 is the airway and breathing person. So pretty similar to what you would do if you're the airway management person in an ACLS algorithm, with a couple of important differences. So you remove the person from the ventilator in favor of bag mask ventilation. And of course, the point of that is to do an accurate assessment of the endotracheal tube. You want to determine whether the ET tube is the cause of the arrest in the first place, right? So feeling for compliance, all those things. But importantly, they actually say that you can put the patient back on the vent once you've ruled out the endotracheal tube as a cause of a problem. Increase the FiO2 to 100% and remove the PEEP. Removing the PEEP, argument being that if you decrease the intrathoracic pressure, you're going to increase the likelihood of getting ROSC and better pressures. And the reason they recommend that is because there are places who practice this protocol with as few as 4 people present in the ICU overnight. And if you do that, you need to recycle people and have them do more than 1 role. So that's why the option to place the patient back on the vent is there. I can say in our experience, we generally have the opposite problem. We have too many people present at codes, even at 3 in the morning. So we generally end up bagging the patient through the code, but you have the option of not doing so. Okay, role 3 is, again, the person responsible for all the electricity. So they are responsible for connecting the defibrillator and administering the shocks if indicated, and then obviously that's if they're directed by the team leader. And then managing the pacemaker if it's indicated. And another important part of this person's role is once they make the transition to sterile drape on the patient and ready to open the chest, this person is responsible for dumping the internal defibrillator paddles onto the sterile field as well, all of which are present on an open chest cart, assuming it's appropriately stocked, which is sometimes a bit of an assumption. But okay, role 4 is the team leader. So this person is obviously similar to ACLS algorithm, is responsible for running the code, sort of responsible for directing traffic and keeping things in check, right? Generally, but not always, the senior clinician present. So that's been, I can say, within the time frame we're implementing this protocol, this became a bit of an issue. So there are situations where if you at night in our ICU, at least, we have an intensivist, we have plenty of critical care nurses, and we have some respiratory therapists. And if you think the arrest is due to an airway event or the fact that they need an airway, if you're the intensivist, it's kind of a hard argument to say, well, you have to run the code and you can't go do the airway. So we left our people the leeway to sort of make a decision on who is most appropriate to run the code. It does not have to be the senior most clinician. There's also scenarios where it's most appropriate for the intensivist present to be one of the 2 people opening the chest while we wait for a surgeon to arrive at the bedside. So things like that. But the way we've sort of interpreted it for our practice is anybody who is trained in the protocol is fully fit and able to run the code themselves. And I've personally seen situations where we've had our nurse practitioners or our PAs run the code, and I've also seen critical care nurses run the code and do a very effective job. So that's the way we treat it. And then obviously closed loop communication, just like any code event, is important, and sort of keeping the number of people in the room and keeping the volume in check is also important. And one of the most important roles of the team leader is immediately upon recognition of the cardiac arrest, a resternotomy team needs to be assembled and needs to be getting dressed and getting ready in the background. So we always teach all of our personnel in the ICU that you're better off opening that chest cart and getting all the materials out and using them, and then not opening the chest than needing to do it and not having opened it and having, the worst thing you can do is delay that process, and then you go through all the other steps of the algorithm, and then you get to the point where you're trying to open the chest and nobody's dressed. So identifying that early and having two people getting dressed in the periphery is always important. Okay, rule 5, drug administration, another one of the, I would say initially somewhat controversial aspects of this protocol for us, but I think personally I can say I've accepted it as common practice now, but the rule based on the letter of the law in the protocol is that you stop all infusions immediately upon recognition of the arrest. Kind of freaks a lot of people out if you're on like several vasoactive drips and things like that. But the thought being, and I can personally say I've seen this happen where I've seen a drug error cause an arrest. So sometimes if the drugs are not what you think you're giving, that can be the cause of the arrest. So the thought is that you take all of it out of the equation altogether, and if you want to restart medications, like if you want to start an epi-drip, you can do so, but you start from fresh. And then obviously the drug administration person is responsible for stopping those infusions upon the direction of the code team leader. And in addition to that, they are the person responsible for administering amiodarone if it's indicated, and the lower dose epinephrine if it's indicated. Okay, role number 6 is the ICU coordinator. So this is the person who sort of is coordinating activity peripheral to the bedside. So, personally I can say if I'm running a code like this, I usually just sort of figure out and it usually ends up being someone like the charge nurse in our scenario, who knows the personnel well. And I usually just figure out who that is, and I say, hey, get 2 people ready to open the chest. And so that's going on in the background while I'm doing the rest of the things. And this is also the person who's coordinating, someone needs to call the attending surgeon and things like that and let them know what's going on so they can be on their way to the bedside. Because obviously the sooner they get there, the sooner things can be under better control. Okay. In situations of limited personnel, kind of touched on this a little bit, so I'll just go over it quickly. But I remember when our first group was sent to Louisville, Kentucky to train in this protocol, we trained with a group from New Jersey who works in a small community hospital who does cardiac surgery. But in their ICU at night, they have 3 nurses and a respiratory therapist. That's literally the people they have present, and they do this protocol. So this is where you go back to the airway person being able to put the patient back on the vent. So that sort of frees that person up. If the person stopped all the medications and there's no more medications indicated, they could also circulate through and get dressed, things like that. Okay, so as for the actual emergency resternotomy, and a cardiac arrest not secondary to VF or VT, so not shockable, and not amenable to pacing, and after exclusion of readily reversible causes such as airway issues and things like that, the emergency resternotomy should ideally be performed within 5 minutes. And the reason is because the next most common causes are tamponade and bleeding, and they are most readily treatable once you're physically in the chest to clear them out. And the other advantage that I've already gone over is the resternotomy also allows for internal cardiac massage, so you get the more effective resuscitation from that aspect as well. And another important thing is that ECMO initiation is an acceptable alternative in ECMO-capable institutions. So this is kind of, I will say, sort of been a blessing and a curse in our scenario, because we do a fair amount of ECMO, and we have ended up in a situation where, also being in an institution where we do lots of fairly complicated cases, it's often not that clear what the appropriate alternative is if the patient arrests. Sometimes, like, for example, if you have a patient who's just had a 4th time sternotomy, it may be risk prohibitive to even go back in the chest at all. So that person may be better served by going on ECMO. So what we end up doing is, while we're functioning to run the code at the bedside, one of the peripheral providers, usually coordinated by the ICU coordinator, that 6th person, is we try to call the attending surgeon on call, and we try to clarify, do you want to go ECMO or do you want to open the chest? And in situations where it's obviously going to be an issue, we try to clarify that beforehand. So if we admit a 4th time sternotomy, we try to clarify with the surgeon what's going to be our backup plan if we code. But as you can imagine, it can get a little bit touchy at times. Okay, So emergency resternotomy can be necessary in up to 2.7% of patients undergoing cardiac surgery. And it's important for all personnel participating in the arrest to be trained to perform the resternotomy. So when we first started doing this, I remember thinking there is no way we're going to have nurses open chests in our unit. And that quickly became not the case at all. I think we had 2 nurses open a chest within 3 months of starting to practice this protocol. So, the fact is, and oftentimes we get, when we send our very young nurses through this training, we get very, these people have barely trained in ACLS, and now we're training them to physically open a chest. And what I tell them is, yes, it's very scary, and yes, it's at the very, very edge of your practice. But first of all, just because you train in the protocol doesn't necessarily mean you're going to be the person opening it. And I can say the nurses that we have had end up opening chests are generally the more experienced ICU nurses. It's not, a 23-year-old nurse who's been out of training for 8 months. But what I do tell them is if you train in this protocol, you are much better able to assist those who are opening the chest. So if you're a little bit familiar with the tools that are in the open chest cart and the tools that they're going to ask for, then you can better assist them in the process. So I do think that it's very beneficial for everyone to go through this training. Okay, so the resternotomy tray itself. So the thought behind this is to keep it as simple as possible. I don't know how many of you guys have seen the actual open chest cart that the operating room will bring over to a CVICU, but it generally has roughly 200 instruments on it, and it's like literally impossible. I couldn't tell you what any of them are, except maybe these 5. But the thought behind this is we have an open chest cart in our ICU, so it's physically there. All we have to do is have one of our personnel wheel it over to the bedside. It takes 10 seconds. You open this thing up, and the resternotomy tray is literally 5 things. It's got a scalpel, it's got a wire cutter, a heavy needle holder, a sternal retractor, and a suction device. And that's literally all that's in it. With the thought being that, you essentially are going to have a person, if you're waiting, sometimes we get lucky and we have a surgeon who's in the unit at the time of the arrest. But if we're waiting for a surgeon to get there, especially if it's 2:30 in the morning and they're at home, then we're stuck with ourselves until they get there, right? So keeping it as simple as possible, especially under situations of duress, keeps it a lot simpler for our staff. Okay, so again, immediately upon recognition of the arrest, 2 to 3 staff members should start preparing. Aseptic technique is obviously preferred, but again, if you really look into the bones of this protocol, everything is directed towards speed. So while aseptic technique is preferred, hand washing is generally presumed not to be necessary, as long as you put the gloves on in a closed sleeve technique. And in the same vein of thought, the skin prep is generally not utilized as the inability for it to dry properly presents a fire risk. So we literally we don't splash iodine on the chest, we don't do any of that. We literally apply a sterile drape and we go. Okay, for the actual act of the emergency resternotomy, so this is obviously a pretty gross oversimplification of a fairly complicated process, but it generally requires 2 people. So when the equipment's ready, the person doing external cardiac massage backs away, and one of the 2 prepped and draped people puts the all-in-one drape on that has the open chest sort of square. Spread the drape out. One person cuts straight down the sternotomy incision, and the harder you cut, the better, because you're not going to cut through the sternum with a scalpel. But you get down to the wires. One person grabs the wire with the wire holder, and the other person cuts the wire, and as they cut it, you pull it out. And then generally, once you get all 5, or usually it's around 5 sternal wires removed, the sternum, if it's a pure tamponade event, the sternum sort of falls open, especially if it was a pretty recent sternotomy, which most of our cardiac arrest patients are. It will fall open, and usually if it's tamponade, it can be relieved simply by that. But then you use your sterile suction to clear the excessive clot and blood. Then you place the sternal retractor and open the patient's sternum. And once you're in there, you want to recognize your structures that are at risk, usually like the Liam to LAD graft or something like that, and then you want to do your internal cardiac massage if you still don't have ROSC. So yes, all this stuff is very scary, especially for non-surgical people. I can tell you myself, when I was first learning these protocols, I was like, wait, I'm going to train all my intensivists to do what? Let alone the nurses and respiratory therapists and all that. But key things to keep in mind are, number one, this is going on while you are, a surgeon is either on their way or they're going to be there shortly. And I don't think there's been very many situations where we get to the point where we're in the patient's chest doing internal cardiac massage and we don't have at least a surgical fellow there. Now, granted, that's just our specific institution, but I think generally, usually by the time we physically get in the chest, we have a responsible surgical provider at the bedside. Okay, So a couple of sort of special scenarios. So outside of the ICU, generally this protocol is not recommended. It's just, it's obviously a pretty dangerous process. And if, the further you get from the ICU, the less trained your people are to do it. So it's generally not recommended as standard practice. However, the other aspects of the protocol, the defibrillation, the pacing, and the lower dose epinephrine, that stuff should still apply to recent sternotomy patients. Time frame for CSU ALS, so generally this protocol is recommended for the first 10 postoperative days, and the reason for that is because significant adhesions start to develop after about 7 to 10 days, so the risk of going back into the chest emergently, especially with a relatively untrained provider, becomes much higher. So what we say is, after 10 days, it's exclusively up to the kind of the purview of the attending surgeon to determine whether we're going to do an emergent resternotomy or not. Okay, special considerations, intra-aortic balloon pumps. Just keep in mind that if they're present, they can tend to confuse you on whether or not there's actual forward flow, because if that pump is still pumping, then it creates a bit of a pulse on the art line, and it can confuse the recognition of the arrest. And obviously, you can pause that to confirm recognition of the arrest. And another important thing is if you have a balloon and it's triggering on the ECG, if the patient's having an arrhythmia or something like that resulting in an arrest, you want to switch that to a pressure trigger so that the balloon doesn't cause more harm than good. Transplant patients, so generally we treat them exactly the same as we would any other sternotomy patient. For clamshell incisions, they can be reopened based on these guidelines, but generally, not generally, I would say in all scenarios, if you're going to do a primary sternotomy, it has to be an attending surgeon, or I guess a surgical fellow in the correct surgical emergency, but we do not allow our other staff, obviously, to do primary sternotomies for hopefully obvious reasons. And then, obviously, when in doubt, confirm with your attending surgeon before. Sorry. The important point here if you have a patient who's a questionable scenario, like maybe they're a VAD or they were a fourth time, into their chest, or they have like the talon closure device or something like that, we tend to try to make a little sign and put it outside the patient's door in the ICU and confirm with the attending surgeon what our plan is in the event of an arrest, so we know what we're going to do if things go awry in that room. VAD or cardiac assist devices. So again, generally they're treated the same as any other patients in terms of their resuscitation, and that applies to the CSU ALS protocol as well. With the important caveat of anybody who's practiced around VADs knows that simply even recognizing an arrest in a VAD patient is not the most straightforward thing in the world. I've seen plenty of VAD patients have fully maintained cerebral blood flow in the event of a VFib. So it's not necessarily such an emergency, and also having people available who are appropriate to troubleshoot the device for device failure is obviously an important thing to keep in mind. Okay, so for non-sternotomy cardiac surgery, I guess the take-home point is you still have the option of ECMO if you're in an ECMO capable institution, but again, the argument of not doing a primary sternotomy in the ICU without a surgeon present hopefully should speak for itself. Guideline implementation. So there's a bit of a transition phase, and I do think we saw a little bit of this. So you're essentially taking experienced providers who have practiced ACLS their entire clinical lives, right? And you're teaching them a very different protocol. It teaches them not to do CPR in certain situations for a specified amount of time and things like that. And then the actual, one of the main dangers to staff is the 3-stack shocks. Obviously, if you're doing 3-stack shocks and someone's used to 1 and then 2 minutes of compressions, there's a risk of someone being exposed to a shock themselves. So just keeping in mind if you're going to implement this type of protocol requires a lot of training and a lot of subsequent recertification of the staff for those scenarios. I think that's about all I got. What questions do you guys have? Are we going to do questions at the end? Okay.
All right. Thanks so much, Dr. Lester. Our next speaker is Dr. Sang Lee. Dr. Lee is currently an associate professor of clinical anesthesiology at Children's Hospital of Los Angeles. He's a member of the OR anesthesia team, difficult airway team, and the pain medicine team. His main interests include pediatric pain management, POCUS, perioperative management of difficult airway, and regional anesthesia. He's going to be speaking to us today on regional resuscitation, local anesthetic, systemic toxicity, or LAST. Please join me in welcoming Dr. Lee.
Okay, thank you for the wonderful introductions, and good morning, everyone. My name is Sang Lee. I'm one of the pediatric anesthesiologists and pain medicine physician at CHLA. And my talk today is going to be on regional resuscitations, local anesthetic systemic toxicity. And let's begin. So the most important slide of my talk, sadly I have nothing to disclose. And so I'm single and ready to mingle with any sponsor. So if you know anyone, please send them my way, and I'll send a small commission your way. And that's not my kit. I found that kit on Google. And a quick overview of today's talk. For the first part, we'll talk about local anesthetic overview, the mechanism, the classification, and then we'll go into the mechanism and clinical presentation of blast. And we'll finish the talk with the management and prevention of blast. So some historical perspective, the first local anesthetic that was discovered was cocaine back in 1880s when a young ophthalmologist in Vienna discovered that you could numb the cornea by infusing cocaine solution on top of it. Of note that cocaine is the only naturally occurring local anesthetic, the rest are synthetic. And cocaine belongs in the amino ester family. Other drugs in this family include procaine, tetracaine, and chloroprocaine. Fast forward to 60 years later, a new class of local was discovered in the lab. These are the amino amines. They're more stable with fewer side effects compared to the ester type. And the drugs in this class include lidocaine, mepivacaine, bupivacaine, bupivacaine, and levobupivacaine. So how do you distinguish between the two classes? It's based on the name. We learned this in medical school. With the amines, you have two I's in the names versus one I in the ester only. For metabolism, for the amines, it's mostly metabolized by the hepatic enzymes. For the ester, it's metabolized by the pseudocholinesterase, which is produced by the liver, but is mainly found in the plasma. In patients who have pseudocholinesterase deficiency, or in patients who are taking anti-cholinesterase inhibitor, like polystigmine for myasthenia gravis, so you have to be careful because the duration for the ester can be prolonged. So to understand how local anesthetic work, I'll do a quick review of nerve conduction. So sorry if this brings back some painful memories from pre-med classes. But on the left side of the picture, you see an interneuron connections with the muscle fiber as a target. On the right side, you see a zoomed-in picture of the axons showing how the signal is transmitted through the axon as electric current from positive to negative. You also see the axon, the swan cell of the myelin sheath, so wrapping around the axons, and you see multiple myelin sheaths around the axon there. So the question is, why don't they have just one long swan cell that covers the whole entire axons? The reason is that as the signal travels down the axon, it loses voltage and loses energy. So the signal has to get regenerated. And at the nobus of Ranvier, on the gaps between the myelin sheath, that's where the sodium channels are located. So that's where the signal gets regenerated, and so that can continue down the long axon. Here, okay, who remembers action potentials and depolarizations? Here is another look at that. So for neuron cells, it normally has a negative resting potential of 70 millivoltage. And inside the cell has a negative charge. You see mostly potassium ions inside the cell. Outside the cell has positive charge and mostly sodium ions outside the cell. With a stimulus, depolarization takes place and the membrane potential changes, allowing the sodium channel to open. So as sodium enters the cell through the sodium channels, the voltage rises up to be more positive. And once it crosses the threshold of negative 55, you have a depolarization event. And that's when you get the nerve generations. And after that, the cell returns back to the resting state of repolarization. That's when you have the sodium, the potassium channels. They pump the potassium outside the cell again, return the cell back to the resting negative potentials. So now we know that the signal, the nerve signal depends on the opening of sodium channels, right? So local anesthetic work by blocking that sodium channels from opening. And so local anesthetic, they're weak bases. In the normal active form, it has a positive charge. So you see the letter BH, that's the local anesthetic. So being ionized, it cannot diffuse through the cell membrane that easily, so it has to lose the proton and becomes more neutral, diffuses through the cell membrane, goes inside the cell, and inside the cell is more acidic, so it gains a proton back into its active form, and it blocks the sodium channel from inside the cell. So by blocking the sodium channel, you prevent the nerve action potential from happening. Here is the same slide again that shows the location of where the most of the sodium channels are located, mostly in the synapses, the dendrites, and around the nodal ganglions or the gaps between the myelin sheets. This slide shows the most commonly used local anesthetic and the dosing. And so for bupivacaine, the dosing is about 2 milligrams per kilogram, and that's without epi. With epi is 3 per kilo. The reason is that epi causes vasoconstrictions, leading to a fewer systemic absorption. So you can use a high dosing. For lidocaine, it's 5 without epi and 7 with epi. If you look at ropivacaine, it's 3 with and 3 without. It's the same. So epi doesn't make a difference to ropivacaine because it has intrinsic vasoconstrictive properties to it already. So you may have heard this before, but what is a cardiovascular collapse ratio? It is the ratio of the drug dosages required to cause cardiovascular side effects compared to the drug dosages required to cause CNS side effects. So the low ratio drugs are more cardiotoxic because the difference between the two is very, very small. And an example of this drug is racemic bupivacaine. Bupivacaine actually has biphasic vasomotor activities at low concentrations. It actually has vasoconstrictive properties, but at normal dosing, at high dosing, it actually has vasodilatation side effects, so leading more systemic absorptions. And you have the high ratio drugs. They're better, they're safer because the difference between the cardiac and CNS side effects dosing is much higher, so they're better, have a better safety margin. And ropivacaine is an example of this drug because it has a dose-dependent vasoconstrictive properties. And too much of the good things can be bad, so we'll talk about next. Well, for the incidence of blast, so this data came out in 2018 by the American Society of Regional Anesthesia, Pain Medicine, when they updated their last guideline. For last incidence in pediatrics, it's about 7.6 out of 100,000 cases versus 27 out of 100,000 cases for adult. So why the difference between the two patient populations? One reason is that for pediatric, almost all the blocks that we do are after inductions. So patients are not going to be able to tell you any of CNS symptoms. And with anesthesia, we all know that it raises the seizure threshold, so there's fewer CNS side effects. And also they have fewer comorbidities. And the volume we use for pediatric is much more smaller compared to adults. And this picture shows the mechanism for LAS. So you have amide and as the local anesthetic get absorbed from site of injection into the bloodstream, and it get transported to the brain and to the heart. There it blocks the sodium channels, it blocks the action potential from happening. And for CNS, you have seizure, metallic taste, and for cardiac, you have arrhythmias and eventually cardiac arrest. More on LAS mechanisms. So besides sodium channels, it also blocks calcium channels, potassium channel, sodium-potassium ATPase, NMDA channels, and enzymes. It also blocks the carnitine isocarnitine translocase in the mitochondria, so preventing the cells from producing energy. On the left side of the screen, you see the QS waveform overlaying the ion movement of the cardiac myocytes. For the cardiac myocyte, it has a resting potential of 90 millivoltage versus 70 of the neurons. And with the phase 0, you have the opening of the sodium channels, and it goes from negative 90 all the way to positive. So that's when the sodium rushes inside the cell. It correlates with the QRS formations, and that will explain for the ventricular contractions. With repolarizations, you have opening of the sodium of the potassium channel and the calcium channels, and that correlates with the T-wave waveform. So you see how by blocking the sodium channel in phase 0, you prevent the ventricles from contracting, so which is very, very bad. And so for the LAS symptoms, this shows the classic progression of LAS symptoms. It usually starts out with CNS symptoms first because the neurons are more sensitive. And then so you have drowsiness, paresthesia, tinnitus, seizures, coma, and then eventually cardiac arrest. But then it can happen in any order. It doesn't have to follow this classic pattern. You can have cardiovascular symptoms way before or only cardiovascular symptoms depending on where you're injecting. If you inject in a high volume in a highly vascularized area, you can have cardiovascular symptoms without CNS symptoms. And next one is like, when does last happen, right? So it usually happens right away, or it can be up to 1 hour after. On the right-hand side, it shows you the bar graph show you the distribution of the onset for last symptoms. So this is based on the data that was collected from 1979 to 2009. About 77 cases were reported. And among those 77 cases, you see that about 50% of the time, you have less than 1 minute onset. 1 to 5 minutes has about 25%, and then 10%, 5 to 10 minutes, and 15% around more than 10 minutes. So from those 77 cases, this pie graph shows the distribution among the CNS versus CNS and versus cardiovascular symptoms. You see about 45% has CNS symptoms only, 11% with cardiovascular symptoms only, and 44% with combination of CNS and cardiovascular symptoms. So we do see that cardiovascular symptom does happen without CNS involvement. For CNS symptoms, more on that, you can have either up or down with the symptoms. For excitation, is due to the inhibition of cortical inhibitory neurons. So you have agitation, you have seizures. For depressant symptoms, you have drowsiness, unresponsiveness, and non-specific or prodromals, you have metallic taste, circumoral numbness, tinnitus, or diplopia. And in 2010 was when ASRA first came out with the last guideline. In the following 4 years, there were 67 cases that were reported. And the pie chart on the right side shows the distribution of the CNS symptoms among those 67 cases. So you see about 40% of patients have prodromal symptoms, 25% with seizures, 25% with loss of consciousness, and 10% with agitation. So the most common symptom that we see are the prodromal symptoms. For cardiovascular symptoms, they actually in two phases. For the early phase, you actually see hypertension is a hyperdynamic state with the tachycardia. The mechanism for this phase is not well known right now, so they're still being investigated. And that followed by the late phase, where you see severe hypertension, peripheral vasodilatations, conduction block, arrhythmias, and asystole. So these make more sense because they're due to the blockade of the sodium channel and calcium channels. Conduction blocks due to the suppression of the spontaneous cardiac pacemaker activities. On the left-hand side, you see the pie chart of the same day of the same 67 patient from 2010, 2014, and you see that about 41% had bradycardia, hypertension, and shock. 15% with tachycardia, and 15% with VTAC VFib, 7% with asystole cardiac arrest. So what do you do when you have a patient who's complaining of symptoms? So first thing, do not give more local anesthetic. Stop whatever you're injecting and put it away. And call for help. Make sure patient has a maintained airway on 100% of FiO2. If they have seizures, the first line of treatment is benzodiazepine is recommended. If that's not available, you can do some propofol boluses, but keep it below 20 milligram at a time, because we all know that propofol causes cardiac depressant, cause more dilatations, right? Consider limited motions early on. And inpatient who are refractory to these treatments, who are still contracting, having seizure activities, consider muscle relaxants to minimize more acidosis and more hypoxemia. And also make sure the airway is secure before you do this, so you don't want to have a paralyzed patient and not breathing. More on cardiac resuscitation. So this is where we deviate from the standard ACOS protocol. For the epinephrine boluses, try to keep it less or equal to 1 mic per kilo. If you do the usual 10 per kilo, you do 1 milligram, it actually causes more arrhythmia and causes more acidosis. Avoid vasopressin too, because vasopressin has been shown to cause more acidosis in these patients. Avoid any nodal blocking agent like calcium channel blocker, beta blocker, and other local anesthetics. So do not give any more local anesthetic. So I know that in the ACOS, we recommend procainamide and lidocaine for arrhythmias, but do not give them because they are aminoamides local anesthetic. So amiodarone is the go-to drug for any arrhythmias. And for patients who fail both vasopressor and lipid emulsion therapy, bypass is the next step. So if you try to notify them as early on as possible. So why does epinephrine is not good for last resuscitation? So in 2008, Dr. Weinberg and his team did a study where they induced cardiovascular collapse in rats by giving them a toxic dose of bupivacaine. And they divided the rats into two groups. One is epi group and one is saline group. And they found that with the epi group, you have high lactate levels, more hypoxemia, more acidosis compared to the saline group. And when you look at the blood pressure, the hemodynamic profile is almost the same between the two groups. So the epi doesn't help improve the situation compared to the saline group. Yeah. And so the question is, when should you give intralipid? The official recommendation is that you should give it right away. In my last 11 years at CHLA, I had about 2 cases of CNS symptoms. So both of these patients were on the floor. They were having ropivacaine infusion through the epidural, and they both had complaints of metallic taste in the mouth. So we just stopped the infusion. We had everything ready. We knew where the intralipid was. We had everything ready. We stopped the infusion, and the symptoms got better. So we didn't have to give intralipid. But then the official recommendation is to give it as soon as possible. So intralipid 20% was discovered to be the treatment of choice for LAS. This was back in 1998 by Dr. Weinberg and his team again, when they discovered that they could resuscitate cardiovascular collapse in rats who were having induced by bupivacaine toxicity by infusion of soybean emulsions that was commonly used in the TPN solution back then. And for lipid emulsion, the dosing is as follows. For a patient above 70 kilo, you can do 100 cc bolus over 2 to 3 minutes, and followed by infusion of 200 to 250 over 2 to 3 minutes. And for a patient less than 70 kilo, you can do a bolus of 1.5 cc per kilo over 2 or 3 minutes, and then followed by infusion of 0.25 cc per kilo per minute. If they don't respond to the initial bolus or the infusion, consider bolus again a second or third time and double your infusion rate. But keep in mind that there is a 12 cc per kilo limit for resuscitations. This picture shows the mechanism of lipid rescue. So lipid emulsion into the bloodstream, it encapsulates the local anesthetic. It travels to the brain and to the heart. It acts as a lipid sink to pull the local out from the active sites and encapsulate them again. And then it acts as a shuttle that would transport the local to the liver for metabolisms or to the muscle for storage for metabolism later. So intralipid is not completely safe drugs. There were reports of side effects of pancreatitis, ARDS, deep vein thrombosis, and for patients on ECMO, you have fat deposition of the ECMO circuit, but also with blood clots in there too. And for these patients we send labs, you can see interference from the lipid. And you can try to do centrifugations to reduce the lipidemia, but then the effect is still there. So you have a patient in the pre-op area scheduled to go on knee scope, and you did a femoral block. So as you were injecting the local ropivacaine, 0.5%, about 20 cc of it, patients started to report having tingling, numbness, seeing double visions. And you take the appropriate measure, treated the patients, the symptoms got better. So what do you do next? Do you proceed with the case or do you cancel the case, right? So the recommendation is that you monitor the patient for at least 2 hours after a limited CNS event. And if patient has a limited cardiovascular event, it's 4 to 6 hours observation, because with cardiovascular, it can recur later, so the longer observation. And if the patient had a systole, and then it's going to be a clinical judgment of how long you want to monitor the patient for. And then do you cancel the case, or do you send the patient home, or do you admit patient for more observation? So that is like personal clinical judgment depending on your discussion with the surgery and how to move forward. For prevention, so here are some steps to help prevent LAS. Number one is ultrasound guided injections. And so ultrasound has been shown to reduce the risk of vascular punctures. And also with ultrasound, you see where your needle is, you see where you're injecting, and you see the spread of the logo outside the blood vessel. And you can use a smaller volume with ultrasound. Do incremental injections, so give a small amount at a time, watch for symptoms. Aspirate prior to inject, make sure you don't see heme with aspirations. You can also use epi as a test dose to make sure that you're not in a vessel. You can do about 2.5 to about 15 mic test dose. But if you use ultrasound, you don't need to do the test dose with ultrasounds. The following patients at high risk for LAS, patient less than 6 months old, because their liver is not fully mature yet, so it takes them longer to metabolize the drugs. For patient with advanced age due to comorbidities, and in patient with CAD, heart failure, low output state because they cannot clear out the local that fast. And in patients with mitochondrial disease and liver disease, they're more prone to acidosis, so be careful with local anesthetic in these patients. So we know that in medicine, the checklist has been shown to reduce risks, errors, and complications. This is the pre-procedure checklist proposed by ASRA and JAGO with the hopes of reducing the risk of wrong block, wrong-sided block, and also alerts you to the availability of airway devices, suctions, and vasoactive drugs, and also like where you can find intralipids. This is the checklist that came out by ASRA in 3 years ago in 2021. So it's basically my talk in one slide. And it tells you what to do and what drug to use. So you start from the left upper corner, patient has symptoms, so you call for help, get the know where intralipid is, right? And then if you decide to give intralipid, the dosing is to the right side. So above 70, you do 100, and then followed by 1 to 250 infusions over 15 to 20 minutes. And then under 70, you do 1.5 per kilo, followed by the 0.25 per kilo per minute infusions. If patient has seizure, make sure patient has an adequate airway, and benzo is preferred. And if not, then you can use propofol less than 20 milligram at a time. And for arrhythmias, be aware that don't follow the usual ACLS protocol. Give epi, small boluses of epi less than 1 mic per kilo, and avoid local anesthetic, beta blocker, more calcium channel blocker, or vasopressin. And then if patient's stable, you can observe for 2 hours after CNS event and 46 hours after cardiovascular event. And I hope you don't have to deal with this, but if you come across a case of LAS, you can go to lipidrescue.org to report your case and also to talk to other providers or asking a second opinion on this website. And that's it. Thank you for your time.
All right, thank you so much, Dr. Lee. Our next speaker is Dr. Michael Liaker. Dr. Liaker graduated from anesthesiology residency at Vanderbilt in 2005. After several years of clinical practice in both military and civilian settings, he completed a fellowship in critical care medicine at the Cleveland Clinic. In 2011, he joined the faculty at Ohio State and was subsequently appointed director of the Anesthesiology Critical Care Fellowship. At the hospital level, he oversees airway management, Code Blue response, and has been instrumental in establishing the hospital's difficult airway response team. Dr. Liaker will be speaking on perioperative resuscitation and life support. Please join me in welcoming Dr. Liaker.
Thank you very much. I really appreciate the introduction, and I appreciate the opportunity to speak to all of you about resuscitation. So the title of the talk is Perioperative Resuscitation and Life Support. So you guys have probably heard of PEARLS. This is a course offered by the ASA as an alternative to ACLS. And I will be talking about that, but I want to talk a little bit about perioperative cardiac arrest and resuscitation in general, not just about PEARLS. So disclosure, I don't have any financial disclosures. I am embarrassed to say I've not actually completed the PEARLS course. So I've read the guidelines, looked at the articles, the algorithms for pearls, and actually some of the slides are borrowed from Dr. David Stahl, who's one of the faculty responsible for putting pearls together. However, I'm not pearls certified. So if anyone's really disappointed and wants to take a nap or go for a walk, that's okay. So the purpose of this talk is all about recognizing cardiac arrest early and implementing highly effective interventions to resuscitate the person from cardiac arrest, because that improves survival. More importantly, if you do have high early recognition, you can prevent cardiac arrest. And no matter how good we are at resuscitating somebody who's dead, we're always going to be better off preventing cardiac arrest in the first place, and the outcomes are always going to be better. So briefly, goals and objectives. We're going to talk about pearls. I have an example case I'll go over, a brief historical perspective because history is kind of fun. We'll talk about some of the risk factors, outcomes of perioperative cardiac arrest, talk about some of the literature about cardiac arrest in general, which applies to resuscitation in the operating room. I'll introduce pearls a little bit more, talk about why it's there, and talk about crew training and how to apply crew principles to resuscitation from cardiac arrest and how we modify that for the operating room. So let's start with an illustrative case. And this is something that happened to me about a year or 2 years ago. The details have been changed to protect patient confidentiality and because I honestly don't remember the details. But let's pretend this was a 75-year-old woman. This actually was a roughly 75-year-old woman having a robotic total abdominal hysterectomy. She has a history of COPD, hypertension, she takes an angiotensin receptor blocker, a few inhalers here and there. Overall, a pretty healthy woman. So we did not really insert any invasive monitors, a couple of IVs, and I did use a non-invasive continuous blood pressure monitor. I think we have the clear site at our institution just because she's on an ARB, she's older. I was a little bit worried about her dropping her blood pressure. So unfortunately, the case took a lot longer than expected. It ended up going for hours and hours. And about 2 hours into it, we started getting a lot of hypotension. We're not really sure what's going on. The end-tidal CO2 is creeping up, so we turned up her ventilation, but she's a little bit bigger. She's on her head, so it's hard to really ventilate her well, and our CO2 is creeping up. We're controlling it as best as we can. And pushes of phenylephrine, pushes of vasopressin turn into a phenylephrine drip, turn into a really high-dose phenylephrine drip. So now we're really worried. There's no bleeding. Surgeons, from their perspective, everything's just fine. She's not fluid responsive, so what's going on? So we duck under the drapes and we send off a blood gas. While we're doing that, also notice, wow, there's a lot of sub-Q emphysema. There's a lot of crepitus everywhere in the patient. Turns out the gas comes back, pH 7.1, CO2 is like 85. Lactate wasn't that high, it was only 2. But at this point, she was in a lot of vasopressor support. So what's going on? Turns out she developed right heart failure from the acidosis. One of the ports must have dislodged, so all the sub-Q air went under her skin, and she inflated like a Michelin person, Michelin woman, and caused acidosis and heart failure. So we switched to epi, added some vaso, eventually put on some dobutamine, managed for RV failure, and she did really well. Case went fine. We ended up going to the ICU. She did stay intubated because she was all inflated, and we were worried about extubating her for airway protection. So I think this is kind of a nice case to illustrate why codes in the operating room, or in this case, just why somebody almost or about to code is different than situations everywhere else. First of all, we recognize this early. So somebody's right there monitoring the patient, and if we'd let this go a little longer, she would have coded, but we were able to diagnose the problem, figure out what's going on, and at least start some interventions to delay cardiac arrest until we can actually figure out what the problem was and treat it specifically. So the reason she got this sick is not because of something intrinsic to her, it's because of what's going on with surgery or anesthesia. So we have specialized resources, we monitor end-tidal CO2, we get gases, sometimes we have TEE. We did not put a TEE probe in her to confirm all this was going on, but we couldn't get a transthoracic echo because of all the sub-Q air. But this seemed like what was going on, and she responded very well to the treatment. So again, the pathology is very different. It's often bleeding, medications, other things that we don't worry about in other settings. And we have specific interventions. So for example, we managed her with an algorithm for RV failure. ACLS does not have an algorithm for RV failure, but Pearls does. So there's a nice little algorithm that addresses, and we more or less followed it accurately. And the other difference is outcomes are definitely better when we avoid codes and when we target therapy for what's actually going on. So what does the Joint Commission have to say about this? The Joint Commission says everyone should be trained, and everyone who participates in resuscitation needs to be trained in resuscitation beyond ACLS. So people should be educated to know what kind of code response systems and what kind of policies and protocols exist at their institution. They emphasize that we don't do this very often, so we need training to make sure our skills are current and proficient. And they also say a one-size-fits-all approach doesn't work for everybody. So this fits very nicely with the concept of pearls for anesthesiologists. Also, ACLS. The ACLS more and more recognizes the peri-arrest period. So not just managing somebody who's already in cardiac arrest, but managing the STEMI or managing the stroke or managing the arrhythmia before the patient actually arrests. And Pearls does that very well. So now a little bit into the history, maybe the fun part here. So resuscitation in some way, shape, or form has been around for hundreds, if not thousands of years. There are probably, midwives have probably been resuscitating babies going back millennia, because it's such an intuitive thing to do. If a baby's not breathing, maybe I'm biased a little bit because I'm familiar with mouth to mouth and all this kind of stuff, but breathing into this baby's mouth seems like the right thing to do if the baby's not breathing. Mentions in the Bible of breathing life into somebody. So stuff like this has probably been going on for a really long time. There are societies organized for the resuscitation of drowning or near drowning victims, and that was published in the late 18th century. However, if you had a heart attack or a malignant arrhythmia, you're screwed. There's not a whole lot to do. We didn't have defibrillation, we didn't have cath labs and all those kinds of things. So if you coded for a cardiac reason, you probably didn't have much of a chance of surviving, and there wasn't a whole lot to do. But interestingly, in the end of the 18th century, that's when galvanic cells were discovered, and it wasn't very long until people started shocking animals and muscles and realized, hey, if we shock this muscle of a dead animal, the muscle moves. And so the idea of like, well, can we shock people back to life? At least people started playing around with this idea. Obviously, this wasn't happening at the time, but it probably did inspire Mary Shelley when she wrote Frankenstein. So 1846, about 100 years later, things changed dramatically. At this point, anesthesia was being used, ether anesthesia, nitrous oxide for surgery. So all of a sudden, you have a lot more reason to resuscitate people because there was a lot of cardiac arrest under anesthesia. And you also have surgeons who have their hands on the body and they can do things like push on the chest. So there's talk about closed cardiac massage pushing on the chest, but pretty slowly. So this is probably more of a respiratory resuscitation. It's a very modern sounding account where they're pushing on the chest in the right place, but they're only doing it 12 times a minute. There are actually considerations or descriptions of occluding the distal aorta to send blood to the brain, which is, again, a very modern concept, but people were doing this because they had their hands in the person already. And internal cardiac massage was also pretty common. In fact, internal cardiac massage was probably more common back then because that was all there was no good description of external massage. So the beginnings of truly modern resuscitation started in the 20th century with George Kreil at the Cleveland Clinic, who really did studies on animals demonstrating that closed chest cardiac massage does work. And William, I'm going to butcher his name, Cohenhoven, he was not even a physician, he was an engineer at Hopkins, and he started experimenting with defibrillation on animals. And thanks to his work in the 1950s, we developed effective defibrillation. And these are the origins of truly modern resuscitation. So looking at a timeline of modern CPR, we see a couple of things. So modern CPR is actually pretty recent. So 1960s is when the AHA really started training physicians to resuscitate patients. And ACLS, I'm actually older than ACLS. That really started in 1979. And then, of course, AICDs became common in the 1990s, ECMO CPR, and in 2018, some articles were published in Anesthesia and Analgesia talking about ACLS for anesthesiologists, describing some algorithms and guidelines to describe situations where anesthesiologists resuscitate an OR and how to better resuscitate somebody from trauma, high spinal, local anesthetic toxicity, as we talked about, and other things that we encounter. Pearls is very recent, offered since 2022. So I was going to do this as a question and answer thing, but in the interest of time, I'm just going to keep going here. But the incidence of perioperative cardiac arrest is about 5 in 10,000. About a third of that is related to anesthesia. So about 1.5 in 10,000 cardiac arrests are due to things that we do, medications, airway issues. The rest, 2/3, are related to what the surgeon is doing. So the surgeons are usually at fault. It's not our fault, it's their fault, right? What's survival from perioperative cardiac arrest? About 35%. And this makes sense because perioperative cardiac arrest is a form of in-hospital cardiac arrest. And it's a form of in-hospital cardiac arrest in a highly monitored, highly specialized setting where we can intervene in ways that we can't intervene in other places, so the outcome's a little bit better than in-hospital cardiac arrest in other areas. Out-of-hospital cardiac arrest, like we talked about, outcomes are terrible, 10%, and most of those are people who get defibrillated. Most of those are shockable rhythms. So what is anesthesia-related mortality? We kind of talk about this sometimes with patients. I don't throw out numbers, but we talk about the risk of something bad happening. 1 in 10,000 anesthesia-related mortality, and if somebody arrests from something directly related to anesthesia, things we do, they typically have a better outcome because these are typically reversible things like airway drug problems. So how often does this happen? This study is about 10 years old now, so it's a little bit dated, but this is a really nice review of perioperative cardiac arrest. So the authors here reviewed the database from Get With the Guidelines from ACLS, and they looked at people who were arrested within 24 hours of surgery. So, and they looked at when they actually grabbed the code card. So if somebody just got, a little bit of epi and maybe 2 or 3 chest compressions, those patients might have been missed. But if they actually grabbed the code card, then this would have been gathered, and they collected a lot of information on the patients to try to describe perioperative cardiac arrest. And they managed to cover 234 hospitals and 2,500 cardiac arrests that would happen within 24 hours. So this is a really nice database. So predictors of mortality, and this is I think, kind of obvious. So bleeding is one of the more common reasons that people don't recover from cardiac arrest preoperatively. Emergency surgery, surgeries that happen after hours, weekends, prolonged hypotension, sicker patients, all that kind of stuff. So basically, sicker patients, bigger surgeries happening after hours, and non-reversible problems like bleeding that can't be stopped. Those are associations with mortality from perioperative cardiac arrest. So again, looking at outcomes from this, so they achieved ROSC, return of circulation, in 60% of the patients that arrested perioperatively. 24-hour survival was 45%, and survival to discharge 30%. So again, very similar to information we have from other studies. And 65% of the survivors had good neurologic outcome. So again, on the whole, comparing this with resuscitation from cardiac arrest in other settings, these are really, really good outcomes. But for those of you doing the math, 20% of all those people who arrest actually survive, and survive with a good neurologic outcome. So if you code in the preoperative setting, even though your odds of getting out of the hospital and having a good neurologic outcome are better, those are still like 80% don't. 80% either don't survive or don't survive with a good neurologic outcome. So the takeaway point is, again, no matter how good we are at resuscitating from cardiac arrest, we're always better off preventing that cardiac arrest ahead of time. Outcomes are always going to be better. So again, data from the study, where do patients code? Most of the codes happen in the operating room. Number 2 was the PACU, then the ICU, purple is the floor, and the little yellow pie wedge is a telemetry unit. And as you can imagine, people arrest for different reasons. In the operating room, it'd be bleeding, maybe an airway issue. PACU, probably mostly airway, maybe arrhythmias, those kinds of things, maybe hypotension, hypovolemia, and ICU, multi-system organ failure, all those kinds of things. So let's look at outcomes. And if you look at survival by location based on the study, you'll see that, well, let's take a look at OR, PACU, and ICU. So these are all patients in highly monitored areas where interventions happen right away. So if you need to be intubated, that typically happens right away. If you need to be shocked, that happens right away. Chest compressions start right away. So in terms of response time, the OR, the PACU, and the ICU are very similar, but the outcomes are very different. The outcomes are best in the PACU because, again, there's typically something reversible going on. This is somebody who, if they're intubated, they can recover, or they just may need to be defibrillated or something else, but the outcomes are best in the PACU. Number 2 is the OR. Typically the cause of cardiac arrest there is bleeding or something else going on with the surgery. And the worst outcomes out of those 3 is the ICU, because ICU doctors do not know how to manage patients. I'm just kidding. But these are truly sick people, and the chance of there being something reversible that we can do is not very good. So if you look at the other two areas, telemetry and the floor, again, these are similar patients. You would say telemetry patients are probably a little bit on the sicker side because somebody decided they need to be on telemetry. However, outcomes in a telemetry unit are better, and this shows that early response time is important as well. So the two takeaway points from looking at this is reversibility and response time are very important in terms of outcome from perioperative cardiac arrest. Kind of obvious, but this proves it. You guys have all probably seen this curve that shows survival and ROSC after cardiac arrest, and you see the two lines. The blue line is survival, the red line is survival with a good neurologic outcome, and you can see how it really drops in around 20 minutes. The chance of you surviving with a good neurologic outcome is very, very, very low. So reversibility is really important, and good high-quality resuscitation is also important to get a good outcome. And what can we do to reverse things? Well, typically it's shock somebody or give epi and identify the causes. So the 20-minute window is really what we have to act and reverse cardiac arrest. And in the meantime, we gotta maintain perfusion. So if good resuscitation is important, can we prove that? Well, yes. So they looked at hospitals and looked at survival survival of the event based on how well the resuscitation algorithm was followed. And again, no surprise, places where, excuse me, this is one hospital, situations when resuscitation was done well and more steps were followed had better outcomes. So appropriate resuscitation does lead to survival. So what does appropriate resuscitation look like? Well, it's all the things you know, and these are actually the quality metrics that our hospital uses on the Code Blue Committee when we look at things. And compression depth, and the 1 inch is confusing. It's really it's 1 inch more. So, but 2 inches of chest compression is important for resuscitation. Maintaining a compression rate of 100 to 120. We tend to be a little fast at OSU, and a higher compression fraction, meaning people stay on the chest longer. All these things make a difference in outcome. And shorter pauses for intubation and rhythm assessment and all these other kinds of things. What you do not see on there is ventilation. Pauses in ventilation don't seem to matter, don't seem to affect outcomes. And if we go a little bit further, this is a little bit of a more recent study. They looked at survival from cardiac arrest based on when patients got intubated, and these are patients got intubated within 15 minutes at many institutions, again 43,000 patients, and they stratified them, people who got intubated like in early, or I can't remember how many groups they used, or people who got intubated later. They try to control for all the other factors, and in fact people who got intubated sooner had less ROSC, less survival to discharge, and worse neurologic outcomes, which is, again, this is not a perfect study because obviously we're not going to randomize people to this, but it does lead us to think that early intubation does not improve outcomes for all the reasons that you can probably imagine, because intubation leads to pauses in ventilation, leads to decreased venous return, and all these other kinds of things that may delay ROSC. So, as much as I am in favor of controlling airways, and I'm not saying this is for all situations, that if somebody has a purely respiratory arrest, securing the airway may be the important thing to do. But if you look at all patients, securing their airway early doesn't really make a difference. So let's look at things that do make a difference. Defibrillation time. We talked, Dr. Lester talked about this a little bit earlier. I think this is actually the same study. So our metric at OSU is to shock somebody within 2 minutes. And if you look at people who get shocked within the first 2 minutes compared to people who get shocked 2 minutes after that, so 4 minutes later, survival drops by 50%. So if it takes 4 minutes to defibrillate somebody in a shockable rhythm, the chance of survival drops by half. So that thing's useful. When they looked at this in the operating room, I think this is actually the same group that looked at it, things were not quite as clear. So in the PACU setting, yes, delays in defibrillation led to a very predictable drop in survival, but if you look at the black table, it's a little bit less clear in the operating room. So defibrillation in the operating room, I'm not saying it's not important, I'm just saying they couldn't identify a clear trend where delayed defibrillation led to worse outcomes. And this is probably because other things are going on in the operating room, bleeding, whatever else. This includes cardiac surgery cases, so I think some of these people might have been put on ECMO and other things. But yeah, but early defibrillation is important. Don't take this to mean that it's not. We're talking about perioperative cardiac arrest, so I included this. So what about epinephrine? So for non-shockable rhythms, epinephrine, as we all know, is important. And yes, for non-shockable rhythms, early epinephrine does increase return of circulation, improve survival to hospital discharge, and leads to a better neurologic outcome. Again, in shockable rhythms, actually early epi did not show that. So if somebody has a shockable rhythm, shocking them is the solution, and if you give epi a little bit later, that's okay. Looking at some literature about post-cardiac arrest management, because this applies to us in the operating room as well too. Do we cool people still? Generally not. The latest data suggests that preventing fever is important, but cooling somebody to 32 to 35 degrees is probably not important. So temperature control, not hyperthermia, is important. That was the TTM2 trial. And there are several trials actually in 2022, all came out in quick succession looking at targets for post-resuscitative care. There's some literature coming out saying that too much oxygen might actually be worse for outcomes in patients who are in shock or cardiac arrest. So they tried to limit oxygen exposure in patients who survived cardiac arrest, and they did not see a difference. For whatever reason, having a more protective or more conservative oxygen targets did not improve survival. Similarly, titrating to a higher map of 63 to versus a higher map of 77 also did not lead to a difference in outcomes. So let's go back to PEARLS and talk about PEARLS a little bit. So PEARLS is a course put out by the American Society of Anesthesiologists for anesthesiologists. It's written by anesthesiologists, and it's intended to treat patients and problems that we encounter in our practice. Who put this together? Here's a picture of some of the people. There's Dr. David Stahl right there, middle of the top row, who lent me some of these slides, and he's one of the people involved in developing this course. The two articles, well, here, I'll skip this. So why was the course developed? Well, because ACLS is designed for anybody to treat any patient in any situation. It's a one-size-fits-all approach. PEARLS is not. PEARLS is, again, targeted for patients that we have, problems that we encounter, and for anesthesiologists who have distinct skills and resources and things we can do perioperatively. So it's different. These are the two papers that came out in 2018. The first one talking about why perioperative cardiac arrest is different from cardiac arrest in other settings, and we talked about all this already. We recognize things earlier, and hence they recommend using lower doses of epi, just like we talked about with local anesthetic systemic toxicity and cardiac surgery ACLS. Lower doses of epi are likely effective in these early situations. They talk about specific situations like LAST, MH, high spinals, pneumothoraces, anaphylaxis, all the stuff that we see more than other people would. Perioperative factors like the anesthetic, the surgery, bleeding, airway issues, like making sure that, hey, if you do turn off the anesthetic, give fluid, and do all these other things that are likely helpful in a perioperative setting that were not going to be helpful in all comers. We have special interventions like ECMO, TEE, open cardiac massage, all those other things, and specific pathophysiologies. I already talked about the first case where the lady that I was taking care of probably had RV failure because of acidosis. So I'm not going to go into all of this, but PEARLS consists of 5 modules. There are interactive scenarios, there are specialized algorithms, there are knowledge checks, and it's I think the whole thing is like considerably less than $200. So considering you're getting almost 6 CME credits, including some patient safety credits, it's actually a pretty inexpensive way to get CMEs, and something that is helpful and is designed for us as anesthesiologists. So PEARLS is kind of new. I said it came out in 2022, and it's evolving. Just like ACLS has updates, PEARLS has updates. They're taking feedback from workshops and conferences and panels. So this is an evolving course, and the content is evolving. moving on from pearls, just something that's really not necessarily in pearls, but I think is important, something that we've done at OSU. I wanted to spend a little bit of time talking about it. So running a code is complicated. We talked about all the things that have to happen, and again, the previous speakers talked about this a lot. So we have to provide good resuscitation. We have to provide chest compressions, defibrillation, push epi at the right time, all these things that we know are important in terms of outcome. We have to identify rhythms, make sure we don't miss secondary, even if the patient didn't have VFib or VTAC to begin with, they might have VFib later in the code. So somebody has to be paying attention to the monitor, keeping track of time. We have to go through the H's and T's, identify reversible causes. We have to document, somebody has to be documenting things, and thinking about post-arrest care. So this team really does need a leader. And as tempting as it is for a lot of these situations, and what we've seen in cardiac arrests at OSU is we tend to stick to the airway. We tend to be kind of quiet. We tend to do things that are probably appropriate, but we don't really stand back and we don't lead the team. And I think that's what's really important. So what we've developed at OSU is a Code Blue Pit Crew. So we originally published the Code Blue Pit Crew for the rest of the hospital, and we adapted this for the operating room. And I do have a little bit of time, so maybe a show of hands. How many of you guys have something like a pit crew that you use anywhere in the hospital, either in the operating room area or just anywhere? Is this something that people talk about, having a pit crew, like where people stand, specific roles, communication? So the pit crew model is basically a way of adapting crew resource management to cardiac arrest. So you need a leader, you need good, clear communication, people need to have a role and not be doing multiple things at the same time. You can't be thinking about H's and T's as you're intubating a patient. So this is something that we've adapted for the perioperative setting at OSU. We're still working on it. It's a work in progress. This is a kind of a culture change, and it's not very easy to adapt. But I guess in summary, for all the reasons that I talked about, if a patient arrests in the perioperative setting, we are the best people to resuscitate them. We know the patient, we know the physiology, we know how to manage them. Pearls is a way for us to get better at it, but I think it's very easy for us to kind of get lost in the weeds sometimes and focus on specific tasks like intubation or looking at the monitor or pushing drugs or something like that. I think the patient is best served in these perioperative codes if we stand back and assign jobs to other people who are qualified to do them. Obviously, if we're the only person who can manage an airway and this person absolutely needs to be intubated, then we might have to jump in there and do that. But I think in most situations, especially with the literature not showing an advantage to early airway intervention, standing back, leading the code, and making sure we do things the right way is probably more helpful for the patient. That's all I have.
All right, thank you, Dr. Liaker. So we're going to move on to the Q&A portion of the lecture. If you have any questions for Drs. Lester, Lee, or Liaker, please come up to one of the microphones, or I guess Darren's going to have a microphone, so if you raise your hand, he'll come find you, and let's just start asking questions to our panel.
Hi, excellent lectures, guys, really. I have a question for our colleagues from Ohio State University. Actually, two questions. One is for your codes. If your codes are anything like ours, sometimes they become, for lack of a better word, shit shows. I mean, there's people all over the place. What we found is that with a lot of new nurses coming on board, and there's a nursing shortage nationwide, we started the implementation of mock codes. We want to try to train people because I think your pit crews are great, and I think we've been doing that as well. But if you have a couple new nurses and a code, they're like deers with their eyes caught in a headlight, right? So we found mock codes and getting people kind of warmed up for the real act has been helpful, and it makes people a little bit less afraid. I don't know. Have you been doing that? Do you kind of recommend that?
So speaking specifically from the CVICU, so Mike, Dr. Liaker is kind of more involved from an institution-wide standpoint than I am. But from a CVICU perspective, we have done mock codes, and I personally think they've been fairly useful. So I don't, and I agree with you wholeheartedly on the whole idea of the nursing shortage. And speaking for our staff in the CVICU, we've had drastic staff turnover. So training them with the institution of mock codes, especially, has been very useful. I think one of the battles we've had personally is a lot of our nurses end up doing night shifts, and we don't do as many mock codes at night, which has been a bit of a problem. So we're trying to shift a little more of that to the night shift. And usually what happens is it ends up happening around 4 or 5 in the morning. So we pull in some day shifters who are going to run the mock code a little early. But yes, we do that. And yes, I do agree that it's very useful.
Second question was, I think you, Dr. Lester, mentioned about getting on the chest within 60 seconds. What do you think about autopulse? Do you think that's going to add anything to our practice, or do you think that's going to be a hindrance?
I'm sorry.
The autopulse, the automatic compressions. Have you? Yeah. Well, there's Lucas Weiss and there's autopulse, and autopulse is one that is the bands around the patient, and you don't actually do chest compressions. You do like a big hugs.
Well, from a cardiac surgery specific, perspective, we do not recommend Lucas devices or any of the external compression devices. I think it's just logistically not a very. It's hard to make that happen in the time frame necessary to for it to be useful, And I think the thought we have for cardiac surgery specifically is that, the risk outweighs the benefit in terms of the danger of the external cardiac massage. I think that's kind of the approach we've taken.
Yeah, I think we've talked about it for the hospital, but I don't think the data's there, and I think that would involve a lot of logistical challenges as well as a lot of training. So I think in terms of resuscitation throughout the hospital, that's something that we've not really pursued because it doesn't seem like there's really good supporting data for using those devices. I think the only time we've used those is when we were building our ECMO CPR protocol, and we had patients coming in from out of hospital cardiac arrest and going to the cath lab, getting cannulated for ECMO. We're using those kinds of devices, but I think that's the only setting we've.
Yeah, regarding bupivacaine use and last, do you have any experience with it's Zin Relief, and it's a bupivacaine and meloxicam polymer? The orthopedic surgeons are injecting it, in TKAs, and that's a 400 milligram dose of bupivacaine. And I had a hard time figuring out how that's being released and how much they're getting in the first 6 or 8 hours. We kind of went through some stuff, and we've reduced our adductor canal block dosages and taken out the epinephrine, just trying to balance what's happening there.
Now, are you talking about Exparel?
No, it's a polymer it's almost like a clear gel, not Exparel, and it's mixed with meloxicam also, and it goes right into the joint space.
Oh,
And
yeah,
as that warms up over about the first 6 hours, there's a slow release, but then you end up with about 200 milligram dose release by hour 12. But there's kind of this front gap, so we were just reducing everything for some of our other blocks. But I was wondering if you'd ran across anything.
Yeah, well, we haven't heard of that drug before, so I don't have experience with it, but I do have experience with Exparel. And we used to do Exparel before they sealed the ASA, so we stopped it. But I think the same concept would apply, because I know with Exparel you should not give any local before Exparel, because that can release everything all at once and can cause a last event. So I would take the same precaution with this drug that you just mentioned too.
Well, even with Exparel, though, they're injecting it around the incision site. Would you still do any kind of block with that?
Could you say that again?
Yeah, if you're using the Exparel right at the surgical site, would you also do an adductor canal with just straight bupivacaine?
I would not. If you do local infiltration, I would not do a block. There's still a dosing limit for Exparel that we use, and usually we did a case series on Exparel with adductor canal. It works pretty well, and we tend to stay below the recommended dosing limit for Exparel.
Hi, Suzanne Huffnagel, Thomas Jefferson Hospital in Philadelphia. I had a question for Dr. Lester. Just a clarification, with the stacked shocks in the cardiac ICU, there's no ventilation between those three, correct?
The protocol itself doesn't really specify whether you're ventilating in between the shocks or not. But I mean, obviously, when you're delivering the shocks, everyone has to sort of clear away. And I think so. If you're practicing the protocol based on if you're doing the act of putting the patient back on a ventilator and putting them on 100% oxygen and lowering the PEEP, I don't think it's as much of an issue, and probably they're continuing to be ventilated. But in our situations, we're stopping ventilation briefly in between the shocks. And I think the time we've done the 3-stack shocks, it all happens pretty fast. And I think a lot of times those shocks are being delivered, if it's within the 60 seconds, a lot of times those shocks are being delivered in the time frame in which they haven't even done a full evaluation of the airway. They've maybe disconnected the patient and provided a breath or two, but we don't specify. But I think in most scenarios, practically, the ventilations are ceasing for the period of the shocks, or at least for the majority of it.
Okay, thank you. And I have a question for Dr. Liaker. Do you think that pearls is going to be required by anesthesia providers? And when do you think something like that would happen?
So, could you repeat the question? Do I think Pearls is going to be
Required, like we are required
got it.
in our hospitals to be ACLS trained and all that every 2 years, but what about Pearls?
Yes, and my understanding is some institutions have replaced their peri-op for Pearl, have replaced ACLS with Pearls for anesthesiology providers, but it's still fairly new, and I don't think there are many institutions that have done that. I think that is what is intended. I think the people who are developing Pearls have that in mind as and they see ACLS as a direct competitor. And again, ACLS, having just done that recently, took a really long time. I don't know if you guys do those online modules, but it says it's supposed to take like 5 hours. I probably spent like 8 or more hours doing those things, and they're really painful. And it seems like they have a monopoly right now. There's a lot of useful information there, but I think those little mock code things they do are very, very confusing. And I had a lot of trouble with them. Maybe it's just me. I don't know. So I think the fact that ACLS has a monopoly on this and their information is not targeted for what we do necessarily, and it's not very convenient to do in a lot of ways, I think makes Pearls a good option. I think it's kind of institution specific, and hopefully more and more places will adopt that. For people who work in the perioperative setting and don't respond to codes throughout the hospital.
Thank you.
I mean, as I understand it, Pearls is going to be much more user-friendly also for the anesthesiologists and anesthesia personnel who are going to do it, supposedly. And that's just based on talks I had with Dr. Stahl, one of the developers of the protocol, is one of Dr. Liaker and I's colleagues. So supposedly it'll be a better scenario for everybody and more appropriate for what we do every day.
Hi, thank you. Oh, whoa, that's hard. Hi, thank you for all of your presentations. For Dr. Liaker, just to piggyback on Dr. Huffnagel, looking to the horizon, it seems to make sense that perhaps the perioperative staff would also be involved in Pearls, since they, like in the PACUs or as you're transporting perhaps the ICU. Do you think that that might be something that they're looking to as well?
That's a very good question. I could see how that would be very, very useful to make sure that we're following the same algorithms and are doing the same things and playing from the same or singing from the same hymn book or whatever the expression is. I'm not sure. I think that might take a little bit of time. I think that's going to run into a lot of I don't know if political is the right word, but I think that's going to require a very big culture change across the board. So I think that would be nice to see because I think perioperative resuscitation includes not just the operating room as we talked about. So I think having the PACU nurses and respiratory therapists who work there follow the same protocol would be very, very useful. But yeah, I'm not sure how. I think that's going to that's going to take some time.
I have a question for you, Jesse. I also work in the cardiothoracic surgical world. Is there anything that you guys are doing at Ohio State to, and I work with private practice cardiac surgeons, anything you're doing at Ohio State to kind of mobilize your surgeons in quickly so that you're not the one having to open the chest at bedside? Sometimes ours want to sleep and they take a little arm twisting and convincing to get them in, but obviously it's better to avoid a bedside reopening if possible.
I don't think we've done anything specifically to change the culture in terms of surgeon availability. That being said, I can say, at least for our group of surgeons, I don't think that's been a big issue for us. I think, sure, there's been a time or two when it's 3 a.m. and they may not answer on the first ring, but I'm not aware of any scenarios where we've had an extended period of time where we haven't at least gotten a hold of the attending surgeon on the phone and had a surgeon or a fellow at the bedside in a pretty reasonable amount of time. Like, I don't think I mean, maybe Mike remembers anything, but I don't think we've had anything where it's been more than like maybe 10 or 15 minutes max, even in the middle of the night, to get a person there. And, honestly, our surgical fellows are not in-house 24/7, but they're pretty good about if someone's sick or someone's now obviously it's not always predictable, but they're pretty good about, I'm going to stay and sleep in the call room if something's going on or something like that. So no, to answer your question, no, I don't think we've done anything specifically to change their availability, but it's not really been a problem for us.
And then I have one more question for you. I'm seeing some of our surgeons put in these new fancy kind of sternal closure apparatuses. So plates, obviously, a lot of folks are familiar with the wires. We all know. Now there's like some cabling systems. Yeah. Are all of those still accessible with just your standard wire cutter?
So, there's some differentiation in the devices themselves. I know that the Talon device requires a screwdriver, which we keep at the bedside, and they're pretty good about bringing that out. We don't really usually have to ask; it's usually there. That being said, I'm actually not aware if we've had to open a Talon device emergently at the bedside, and I forget. Sorry, I'm getting my devices mixed up, but there was one fancy closure device that you can actually cut, and there's one that requires a screwdriver. And I know the Talon requires a screwdriver, but I don't think maybe we've just been lucky and threaded the needle. But we try to be as proactive as possible. But I kind of think there's only so much you can do in terms of being, we're already asking providers to be a lot of times at the very edge, if not outside their comfort zone in their involvement in these arrest situations. So asking them to be able to appropriately unscrew a Talon device is probably, not really in the realm of possibility, in my personal opinion. And the other thing I'd say is we're lucky enough to be in an ECMO institution too. So in those situations, I think oftentimes we would defer to peripheral VA ECMO.
I do have one question for you, Sang. The 2 patients that you had that you were concerned about last, you said they were both epidural patients. What kind of triggered you to be concerned about last in those patients?
So for those patients, I think they were on a post-op day 2 or 3, and we were having just epidural infusion right on the floor. And we did everything based on the weight, dosing limit. We stay below the toxic limit. But still, you still see the last symptoms in those patients. And was maybe the catheter migrated, got into a vascular structure? Nobody knows. So we stopped it, we took it out right away, and the patient got better.
Okay. So you removed the epidural at that time too. That's what
Yeah.
Often the epidural dose is so much lower than the last.
Yes, but they
Doses, right?
accumulate because for pediatric, we try to stay. There's an infusing limit that we try to stay below, based on the weight, and over 24, 40 hours, they accumulate, and also depends on how fast the patient metabolizes too. Some are slow metabolizers, so just get more toxic that way.
If not, I think we can adjourn a little bit early. We're going to take a quick break for coffee and restroom breaks, and then we'll be back for the next session.